Good evening, everybody. Welcome to this evening episode of Pursue, and we have Pursue 6L, which is liver and GI and pancreatic pathology, and we are streaming live from Institute of Medical Science BHU via Kolkata. And the topic of today is very interesting, which is GI lymphoma. And to talk on that, we have Dr. Ojas Gupta, who's an MBBS from Kolkata and MD from PGI Chandigarh, a DNB. He has also done a PDCC in Renal and Transplant Pathology from PGI Chandigarh. Presently, he is an assistant professor in the Department of Pathology at IMS-BHU Varanasi, and he's got several publications in indexed national and international journals. Before I ask him to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Ojas Gupta, sir, please share your screen and start the presentation. Thank you. Yeah, we can see your screen. Yeah, please start.
Yes, sir. Thank you, sir, for your kind introduction. Yes, and giving me this grand opportunity. So first, I'll pay my sincere regards to the teachers, colleagues, and residents of my alma mater PGI Chandigarh, and also to my seniors, teachers, and colleagues of my current affiliation at IMS-BHU Varanasi. So, this topic of GI lymphoma, I'll be discussing briefly. I'll be discussing on 8 points, and starting briefly, I'll start from the development of lymphoid neoplasm. I'll cover normal lymph node histology, immune system of the GIT, WHO classification of GI lymphomas, the sites and prevalence of GI lymphomas, and then after I'll shift to case-based approach, which I'll include 8. I've included 8 common cases which are related to GI lymphomas, and then I'll cover the very rare entities very briefly. And finally, I'll talk about the CAP reporting format, which will include staging, prognosis, and B symptoms. So most of the content of this topic I've taken from these 2 standard textbooks. So because B cell and T cell neoplasm recapitulate stages of their differentiation, that's why it's important to understand the immune system. So the immune system has 2 major subsystems, and these 2 subsystems differ in nature of their targets and the types of immune responses. So we have innate and acquired immune system. Innate immune system is the first line of defense, which has a major role in barrier immunity, which includes mucosal and cutaneous defenses, and it is mediated by gamma delta T cell, NK-like T cells, NK cells. Toll-like receptors are used, and after that cytokines and chemokines and complements are used to cause apoptosis and necrotic cell death pathways. The adaptive immune system, it is based on the immunological defenses, and it is characterized by specificity and memory. Here B and T cells are involved, with including their specific B cell receptor and T cell receptors. Antigen presenting cells are required to present antigens with the help of MHC receptor complex to T cells, and antigen specific receptors are present on B and T cells. So because B and T cell lymphomas recapitulate their morphogenesis, so we'll start with the morphogenesis of B cell. So the precursor B cells mature in the bone marrow. They undergo apoptosis or they develop into mature naive B cells. These naive B cells, after antigen exposure, they either develop into short-lived plasma cells or they enter into the germinal center and they become centroblast after somatic hypermutation and heavy chain class switch. These centroblasts will transform into centrocytes, and later on these centrocytes will undergo either apoptosis or they will form long-lived plasma cells which will secrete immunoglobulins, or they will transform into memory B cells or marginal zone B cells. Now it is important to understand that the lymphomas which arises from the precursor B cells, these are B lymphoblastic lymphoma, and the lymphoma which arises from the pre-germinal center cells, which are naive B cells, which are CD5 positive, is mantle cell lymphoma. And the lymphoma which arises from the germinal center are follicular lymphoma, Burkitt lymphoma, some of the DLBCLs, and Hodgkin lymphomas. And the cells which arise from the post-germinal center neoplasm, that is plasma cells, memory B cells, or marginal zone, they include marginal zone or Malt lymphoma, lymphoplasmacytic lymphoma, CLL, SLL, some of the DLBCL or plasma cell myeloma. Also, it is important to understand that whenever these B cells are in a specific stage, they acquire some marker and they lose some marker. For example, when a germinal B cell will acquire CD10, BCL6, which is characteristic of a germinal center marker, and LMO2 and HGAL. Whereas when they will shift to the post-germinal center neoplasm, they will lose these germinal center markers, that is CD10 and BCL and 6, and they will acquire IRF MUM1. So it is important. Next we move on to the T-cell morphogenesis. So the T lymphocytes which arise from the bone marrow precursor, they undergo maturation and acquisition of function within the thymus. Now the T cells which recognize cell peptides are eliminated by the apoptosis. So these T cells are initially double positive, that means CD4 and CD8 both positive, and when they differentiate, they become individually positive like CD4 or CD8. Also, from these subcapsular cortical thymocytes, there arises gamma delta T cells. These gamma delta T cells are only less than 5% of the normal T cells, and they lack CD4, 8 and 5 markers. They are specifically situated in spleen, mucosa, peripheral blood and the skin. Now, apart from the gamma delta C cells, so these gamma delta is nothing but the T cell receptor, and the other T cell receptor is alpha beta. So the T cells which are mainly present in the periphery are either naive CD4 positive T cells or helper T cells, which will transform into helper 1, helper 2, T follicular helper T cells, T regulatory T cells, or TH17 T cells. And cytotoxic T cells, that is CD8 positive, will transform into memory T cells or effector T cells. Here also we can see that germinal center marker, which is specific for this follicular helper T cells, is positive in these T cells, that is CD10 and BCL6, and the rest of the T cells have their specific markers which are recognized. For example, T regulatory cells have FOXP3 and CD25. Also, we should understand that CD7, which is a pan T cell marker, is also helpful in our immunohistochemistry or flow cytometry. Now, let's move on to the lymph node. So, a lymph node has mainly 4 parts: cortex, peripheral cortex. In between these lymphoid follicles are the paracortical area, the medullary region, and these are the sinuses. So the cortex is predominantly comprised of follicles. Follicles are primary and secondary. So usually they have a primary follicles, but when the lymph nodes become reactive, they acquire germinal center, which is light stain looking area in the center of these primary follicle, and they transform into secondary follicles. Now let's see how this secondary follicles looks like. So this secondary follicle, when we go from inside to outside, it has the center germinal center, followed by the rim of mantle cell, and followed by the rim of marginal zone. So this germinal center, when we see carefully, it has got 2 poles. One is a darker stain pole and another is the lighter stain pole. This darker stain pole comprises predominantly of centroblast, and the lighter stain ones comprises predominantly of centrocytes. The darker ones are situated within the inner aspect of the lymph node, and the lighter ones are situated towards the periphery or towards the subcortical sinus. Also, we can see there are intervening tangible body macrophages. So this differentiation of dark stain and light stain within the germinal center is known as the normal polarity of a lymphoid follicle. Followed by now this mantle zone, it comprises of small mature naive B cells which are compactly placed in this mantle zone, and is surrounded by this marginal zone which has different cells like centrocyte, centroblast, immunoblast. We will see their morphology also. Now, why it is important to see the lymphoid follicle architecture? Because a neoplastic follicle will lose all these architecture. For example, when we compare this lymphoid follicle, which is a neoplastic follicle, we can see that there is no polarization of darker or lighter stain. There is loss of very scant amount of mantle zone, and there is absence of tingible body macrophages. So this neoplastic follicles is completely replaced by the neoplastic cells or abnormal lymphoid cells. Now, the normal germinal center comprises of numerous centrocytes, which are small, which have cleaved nuclei, and they have got hyperchromatic nuclei and inconspicuous nuclei. Also, there are scattered immunoblasts, which have centrally placed basophilic nucleoli. Additionally, they have centroblasts, which have peripherally placed nucleoli, and some small mature B cells. So these follicles are predominantly composed of CD20 positive B cells, whereas the T cells are predominantly present in the interfollicular region. In the follicles, there are T follicular helper cells. Also, in a reactive lymph node, there are many cells which express BCL2. BCL2 is an anti-apoptotic marker. So this BCL2 expression is shown by all the cells present in the lymph node, but excluding the lymphoid follicle. So why it is important to know BCL2? So BCL2 is a family of protein which is an anti-apoptotic protein. It maintains the integrity of outer mitochondrial membrane, and it prevents the leakage of cytochrome C and other death-inducing proteins into the cytosol. So this figure I have taken from the Robbins, and it clearly depicts that activation of BCL2 is important to make a cell immune to apoptosis. So after this, let's move on to the immune system of the GIT. So our upper aerodigestive tract, it comprises of extensive lymphoid tissue in the Waldeyer rings, which include tonsillar and adenoid elements, followed by esophagus and stomach. These are normally devoid of such lymphoid follicles. The reason being, there is rapid transit of food, and they have chemically hostile environment for microorganisms, which is provided by salivary and gastric secretions. So, presence of any kind of mucosa-associated lymphoid tissue within the esophagus and stomach is usually a pathological state, which can be due to any viral or fungal infection, reflux esophagitis, or Helicobacter gastritis. The large and small intestine, they normally possesses mucosa-associated lymphoid tissue, and they are maximally concentrated in the terminal ileum and the appendix. So let's see the normal elements of immune system of the GIT. So a GIT, gastrointestinal tract, has mainly three components of the immune system. The first and the prominent one is the mucosal lymphoid aggregate. The second one is the laminopropria lymphoid cells, and the third one is the intraepithelial lymphocytes. So this mucosal lymphoid aggregate are functionally and anatomically similar to the miniature lymph nodes, and their follicular architecture is also homologous to the lymph node. We can compare it with the previous lymph node structure. However, there are two exceptions. Exception number one is the follicular mantle zone, which is also known as dome cell region. It's eccentrically located along the mucosal aspect. Number two is the presence of membranous epithelial cells, or the M cells. These are a specialized attenuated zone of mucosal epithelium for the free delivery of antigens. We should appreciate that in the mucosal lymphoid aggregates, there is absence of any lymphatics for the antigen delivery. Hence, the antigens are delivered from the mucosal aspect directly. So, there is a significance of these M cells. The next important structure is the laminopropria lymphoid cells, which are mostly comprised of plasma cells and predominantly helper T cells. Small numbers of macrophages and dendritic cells are also seen, which usually present antigen. Next is the intraepithelial lymphocytes. These are universally present in small numbers, and they are predominantly of cytotoxic T cells. which mediate enterocyte lysis in response to viral or any other infections. So, how to approach to GI lymphomas? So, a possibility of lymphoid malignancy is suspected whenever there is clinical and endoscopic observations are highly suggestive of a lymphoid malignancy. For example, there is mass lesion, there is ulcer which is not responding to any treatment, or along with, and then we have to compare the microscopic appearance. Also, IHC markers plays a very important role in the diagnosis of GI lymphomas. So, we can divide the GI lymphomas based on what structures they are involving in the GI tract. For example, if there is lymphoid hyperplasia, so lymphomas which can be seen are follicular lymphoma, mantle cell lymphoma, Burkitt lymphoma, or PTLD. If there is proliferation of acquired myelin tissue, there can be Malt lymphoma, mucosa-associated lymphoid tissue lymphoma. If there is proliferation of lamina propria immune elements, so there can be EPSID, plasmacytoma, peripheral T-cell lymphoma. And if there is proliferation of intraepithelial lymphocytes, then there can be enteropathy-associated T-cell lymphoma or monomorphic epitheliotropic intestinal T-cell lymphoma. So this is the 2019 WHO classification of hematolymphoid tumors of the digestive system. It is mainly divided into site-specific hematolymphoid tumors and hematolymphoid tumors occurring with some frequency in the digestive system. In the site-specific category, we have Malt lymphoma, duodenal type of follicular lymphoma, EITL, MEITL, ITL, hepatosplenic T-cell lymphoma, follicular dendritic cell carcinoma, sarcoma. And in other lymphomas, we have DLBCL, the most common, followed by follicular lymphoma, mantle cell, Burkitt lymphoma, plasmablastic lymphoma, PTLDs, and others. So, when to say whether the primary lymphoma is of the digestive tract? So, there are two basic criteria. So, the strict criteria says that the lymphoma should be extranodal, it should arise in a specific site of the digestive system, with the bulk of the disease should be localized at that site with or without regional lymph node involvement. However, the most commonly used or the less stringent inclusion criteria is the contiguous involvement of other organs for any distal lymph node disease, provided the extranodal tumor is presenting site and constitutes the predominant disease. So here, the presenting site and the predominant disease is in the GIT tract. Now, let's categorize how the GI lymphomas are categorized based on the cell of origin. So, among the B-cell lymphomas, the most common is the diffuse large B-cell lymphoma, which constitutes 55 to 69%. It is most commonly situated in the stomach and ileocecal region. The extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue or Malt lymphoma, which includes immunoproliferative small intestinal disease, is most commonly seen in stomach and small intestine. Follicular lymphoma, which constitute less than 4%, are seen in small and large intestine. Duodenal type of follicular lymphoma is seen, as the name suggests, in the duodenum. Mantle cell lymphoma, which constitutes 3 to 10%, it can occur in any site of the GIT. Burkitt lymphoma, which most commonly seen in the children and adults. Young adults are most common in the ileocecal region, stomach and small intestine. Plasmablastic lymphoma can occur in anorectum and other parts of GIT, and post-transplant lymphoproliferative disorder or PTLD can also occur in any site of GIT. In the T-cell and NK cell lymphoma, the enteropathy-associated T-cell lymphoma is seen in around less than 5% of the cases, and it is seen most commonly in the small intestine. Monomorphic epitheliotropic intestinal T-cell lymphoma is seen in small intestine commonly. Other ITL, ITCL, NOS, indolent T-cell lymphoproliferative disorder or GIT, these are seen in both large and small intestine. Other lymphomas like EBV positive inflammatory follicular dendritic cell carcinoma is seen only in liver. Systemic mastocytosis, LCH, these are seen both in GIT and liver. Follicular dendritic cell carcinoma is seen in GIT, pancreas and liver, and histiocytic sarcoma is seen in GIT. So let's move on to the most common site of so GIT is considered as the most common site of extranodal lymphoma, which is 30 to 40%. And among the GIT, the most common organ which is involved is the stomach. The stomach is involved in around half of the GI lymphomas, and the most common ones are DLBCL and Malt lymphoma, followed by small intestine, where most commonly affected areas are ileum and ileocecal region, and here also DL B cell is the most common. This is followed by large intestine, then liver, esophagus, and the rare ones are seen in pancreas, gallbladder, and extrahepatic bile ducts. So this is from Chandigarh. So Chandigarh is located in the foothills of Shivalik. It is one of the early planned city of India. This pic is from the rock garden, which is completely built from the industrial waste and home waste and the discarded items. We can see these beautiful ladies are made with the help of the bangles, broken bangles, and some other discarded items. So after that short introduction, let's move on to the case-based scenarios. So case number 1, we have got a 61-year-old gentleman. He had he had a long-standing pain on abdomen. His blood test and stool antigen test for Helicobacter pylori were positive. On endoscopy, the endoscopist found superficially depressed lesions with the focal mass forming in the stomach, which is better highlighted by this endocarmine dye. So here we can see that this is the biopsy, GI biopsy, and it has got intact mucosal lining. So we can see that there is diffuse proliferation of these blue-looking cells, and these are atypical lymphoid cells, which are presented predominantly in the mid and the lower aspect of the lamina propria, and also involving the underlying submucosa. On low power itself, we can also see that there is gastric glandular destruction, and on higher power, we can see that there is splaying and fragmentation of these muscularis mucosae. So these lymphoma cells are causing destruction of these muscularis mucosae, and they are transgressing into the submucosa. So on closer power, we can appreciate that these lymphoma cells are basically comprised of polymorphous population with these small cells with having nuclear cleaving, and they have got a hyperchromatic nuclei. These are like centrocyte cells, and there are intervening small immunoblast-like cells. Some are centroblast-like cells. So these cells are causing destruction of these glandular epithelium, and they have a eosinophilic degeneration of these cells. So this is called as lymphoepithelial lesion, and it comprises of aggregates of more than or equal to 3 marginal zone cells. So we are dealing with some marginal zone lymphoma, and these are less prominent seen in non-gastric side, so these are most prevalent in the gastric side. On performing IHC, we found that these cells were composed predominantly of CD20. They were negative for CD3, and CD43 better highlighted these lymphoma cells, which is a marker of marginal zone lymphoma. So the diagnosis is extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, which is Malt lymphoma. So what are the essential diagnostic criteria? Involvement of extranodal site, diffuse to perifollicular infiltrate of centrocyte-like cells, small lymphoid cells, often with scattered large lymphoid cells. There can be monocytes and plasma cells, which may or may not be present. They will be positive for B lineage markers like CD19, 20. Immunohistochemically, we have to exclude mantle cell lymphomas, which are CD5 positive and cyclin D1 positive, and follicular lymphomas, which are CD10 and BCL6 positive. So the desirable diagnostic criteria, if there is a lymphoepithelial lesion present, so we can say by surety that these are Malt lymphomas. Now, the life is not very easy. So we have to differentiate between the borderline cases. So there are certain points which are helpful to us, which can point toward the right diagnosis. So presence of lymphoepithelial lesion, that is a destructive lesion, basally located too many CD20 positive B cells, infiltration of the muscularis mucosa or splaying of the muscularis mucosa, expansion of the CD20 positive B cells with monocytoid or marginal zone distribution pattern, follicular colonization, and there should be lack of active gastritis. That means there should not be any neutrophils. If there is lack of H. pylori with an atypical lymphoid infiltrate, it increases the likelihood of a lymphoma. So even in 1993, Witherspoon gave histological scoring for the diagnosis of Malt lymphoma. So it was not that easy previously also. So the grade 1, which is the highest grade, was given as low-grade B-cell lymphoma of Malt, and the histological features were presence of dense, diffuse infiltrate of centrocyte-like cells in the lamina propria with prominent lymphoepithelial lesions. The grade 4 was given to suspicious lymphoid infiltrate, probably lymphoma, grade 3 to probably reactive. So the difference between these two were the presence of occasional into epithelium and presence of diffuse infiltration into the lamina propria with presence of these lymphoid cells into the epithelium in small groups. So coming to the definition, so Malt lymphoma is an extranodal low-grade B-cell lymphoma. It arises in a mucosal or granular tissue. It recapitulates the cytoarchitectural features of mucosa-associated lymphoid tissue, that is Malt, and Pierce patches is the most common prototype of these Malt, which is usually seen in reactive conditions. So Malt lymphoma has a subtype which is called immunoproliferative small intestinal disease. It is also known as alpha heavy chain disease, and it is most commonly seen in small intestine and mesenteric lymph nodes. So here, as in Malt lymphomas, we usually see the marginal zone cells, but in IPS we see usually a lot of plasma cell differentiation. So these Malt lymphomas are basically caused by long-standing infection, autoimmunity, or other things like gallstones. So Malt lymphoma is most commonly seen, external Malt lymphomas are most commonly seen in the stomach in 70% of the cases. They're mostly associated with Helicobacter pylori in about 85% of the cases, but their incidence is reducing as the use of PPI and antibiotics are increasing. Also, whenever there is translocation of BRC3 and MALT1, these Malt lymphomas become resistant to the treatment of H. pylori. IPSIT, which is most commonly seen in intestinal tract, is caused by Campylobacter jejuni. They also have a similar kind of mutation in around 12 to 56% of the cases. Liver is involved in 10% of the cases, and the etiology is infection, both infection as well as autoimmunity. So hepatitis C virus is responsible for 23, hepatitis B for 16% of the cases. Here also H. pylori is also one of the causative agent, which in 13% of the cases. In 12%, they have autoimmune hepatitis, primary biliary cirrhosis, or Sjogren syndrome, and other infection like ascariasis and synchronous malignant tumors are seen in 4 and 11% respectively. Gallstone is responsible for Malt lymphomas in gallbladder and extrahepatic biliary disease with similar kind of translocation. So this is a figure of hepatic Malt lymphoma. So we can see that there is a dense lymphoid infiltrate with portal and parenchymal involvement, and on a higher power view we can see the monotonous proliferation of centrocyte-like cells forming lymphoepithelial lesions with the bile duct epithelium. So on immunophenotyping, it has similar to the marginal zone B cells. That is, they will be positive for B cell marker, that is CD20, CD79A. They will acquire BCL, they will have BCL2 positivity. They will have surface IgM immunoglobulin positivity. Also, they will be positive for CD43, MNDA1, and weekly 11C. They will be negative for germinal center markers because the marginal zone is post-germinal center disease. So prognosis, H. pylori eradication result in almost complete remission, almost 60 to 100% of the gastric Malt lymphoma. However, the translocation 11-18 confers resistance to this H. pylori eradication therapy. So these two are, this is a low power view which is showing gastric mucosa after regression of the marginal zone lymphoma. It shows pale hypocellular lamina propria. And on the higher power view, we can see that lamina propria contains only loose connective tissue, fibroblast, and rare lymphocytes. So we can see that the therapy, it is so very good to the response to the therapy. So after Malt lymphoma, let's move on to the second case. So now we have a 60-year-old lady who presented with long-standing abdominal pain and discomfort. There was no hematemesis or bleeding per rectum. On endoscopy, we found white nodules in the second part of the duodenum. So these are those white nodules in the second part of the duodenum. A biopsy was done, and it showed these duodenal villi and the lymphoma cells which forms neoplastic follicles here. These are densely infiltrating the lamina propria and even to the villi also. And on the higher power view, we can appreciate that these uniform lymphoma cells are seen which are without any tangible body macrophages. We can see that these cells are showing angulated morphology. They are hyperchromatic nuclei. They are more like a centrocyte kind of cells. Immunochemistry, histochemistry was performed, and for follicular dendritic cells, CD20 was done, CD21 was done, and it showed the relocalization of these follicular follicular dendritic cells into the periphery. CD20 highlights these neoplastic follicles to be comprising of B cells. It was low in proliferative index, and it was positive for germinal center markers, that is CD10, and it was also positive for BCL2. We previously saw that in the germinal center BCL2 is negative, but here it is positive. So this is pathological. So the diagnosis is duodenal type of follicular lymphoma. Now the essential diagnostic criteria are lymphoma, which is confined to the mucosa and or submucosa of small bowel, and most commonly it is seen in the duodenum and also specifically into the second part of the duodenum. The neoplastic follicles are predominated by centrocytes. Here the lamina propria is also infiltrated, and on immunophenotyping we can see CD20 positive, CD10 positive and BCL2 positive. The duodenal type, duodenal type follicular lymphoma, also known as primary intestinal follicular lymphoma, these are the neoplasm of follicular B cells. So they have got a follicular architecture. So they have got a highly characterized clinical and biological features. They present most common in the second part of the duodenum. They have got low histological grade, enroll in clinical course, and they have got an excellent outcome. So they comprise of 4% of all the GI lymphomas with a similar male to female ratio. So genes and protein expression profiles, so they show similar to the nodal follicular lymphoma, that is translocation 1418 between IGH and BCL2 genes. These are, so why they are only located to the mucosa? So the reason is the site in which relevant antigen is encountered to them, and they express specific homing receptors to these mucosas. On histopathology, we have already seen that these are neoplastic follicles, and they are usually of grade 1 and 2. We'll see the grades of follicular lymphoma, and they typically commonly show polypoidal architecture. On immunophenotyping, they are positive for B cell marker, that is CD20, germinal center marker, that is CD10 BCL6, anti-apoptotic marker BCL2. They've got a low Ki67 proliferative rate, that is low Ki67, and as we have already seen that follicular dendritic cells redistribute to the periphery of these follicles. They've got an excellent prognosis, and they've got a low risk of progression to the nodal disease or large cell transformation. So a wait and watch approach is mostly preferred in duodenal type of follicular lymphoma. So after this, we move on to the third case. So now we have a 45-year-old gentleman who has a history of abdominal pain, diarrhea and weight loss. He was a known case of celiac disease since 13 months. So there is some already gastric pathology is present since a long duration and who is not responding to gluten-free diet. Now this patient is presented in emergency with acute abdomen. On intraoperative finding, the surgeons found that he had jejunal perforation. A resection and anastomosis were done, and we received the specimen. So here we can see that the small intestine is dilated, and on the serosal surface we can see these serosal exudates which are covered by fibrinopurulent exudate, which has a result from the perforation most likely, and there are a lot of congestion. The small bowel was open and they reveal multiple small ulcerated lesions without any discrete mass. On higher power view, we can see one of the circumferentially oriented linear ulcers. So sections were taken, and this is the photomicrography. On a microscope, we see that there are sheets of pleomorphic medium to large cells. Some multinucleated and multilobated cells were also present, and they exhibit anaplastic morphology. On immunohistochemistry, they show positivity for CD3. The larger cells were typically show positivity for CD30, and they were positive for toxic toxic markers like granzyme B. So there were changes in the surrounding mucosa. Apart from these larger atypical cells, there were other cells also like eosinophils, neutrophils, some plasma cells. And also in the adjacent mucosa, we found the features of celiac disease, that is villus blunting, crypt hyperplasia, and presence also we found that tumor cells were present in the submucosal blood vessels, which is deep to the muscularis mucosae. There were an increased number of intraepithelial lymphocytes on seeing a higher power view, and there were reduction in the goblet cells. So the diagnosis is enteropathy-associated T-cell lymphoma. Enteropathy, here in this case, is celiac disease. So what are the essential diagnostic criteria? The intestine infiltrated by pleomorphic medium-sized to large epithelial, large lymphoid cells, which may even be anaplastic. It is accompanied by variable inflammatory background, often including many eosinophils and histiocytes. The uninvolved intestinal mucosa show features of celiac disease, like villus atrophy, crypt hyperplasia, intraepithelial lymphocytes, and they will be positive for T-cell lineage markers. They will show negativity for CD4 and CD8 and express cytotoxic markers. And the larger cells will be positive for CD30. So these are intestinal T-cell lymphomas, and they are derived from intraepithelial lymphocytes. So we previously saw the approach of these GI lymphomas, so they arise from the intraepithelial lymphocytes. They occur in individuals with celiac disease, and they are seen in less than 5% of all the GI lymphomas. The most common site is jejunum, and they can disseminate to abdominal, lymph node, bone marrow, liver, and lung in around 10 to 20% of the cases. Around 1/3 of the cases arise from the refractory celiac disease type 2 in extraintestinal location. Now, what is refractory celiac disease? So this is seen in 0.3 to 1% of the adult onset celiac disease. Refractory celiac disease is persistent villus atrophy and fail to improve clinically or develop recurrent malabsorptive symptoms and signs despite on strict gluten-free diet for more than 12 months. Now, this RCT is divided into type 1 and type 2 based on absence or presence of abnormal intraepithelial lymphocytes. Now, what are these abnormal intraepithelial lymphocytes? The intraepithelial lymphocytes which express cytoplasmic CD3 but lack surface CD3, CD8 and T-cell receptor expression. So, how to say whether they are absent? So, on flow cytometry, a cutoff limit of less than 20% is set as absence and more than 20% is set as presence. And on IHC, these abnormal IELs should be negative for CD8 and the proportion of negative cells should be less than 50% for them to be absent and more than 50% to be present. So RCT1 is more common whereas RCT2 is rare. On histopathology, RCT1 has features of uncomplicated celiac disease, whereas RCT2 has severe villus atrophy, mucosal ulcer, and ulcerate, which is also called ulcerative jejunitis. RCT1 has a benign growth, whereas RCT2 has considered as a low-grade lymphoma of IELs or EATL in situ. The propensity to transform into EATL within 5 years is nil for RCT1, whereas it is 30 to 52% in case of RCT2. And 5-year survival rate is poor for RCT2 in comparison to RCT1. So let's look how to diagnose RCT2. So in this picture we can see one of the duodenal villi, and it is showing the presence of these intraepithelial lymphocytes, and these intraepithelial lymphocytes are showing strong and diffuse cytoplasmic positivity for CD3, whereas it is absent for CD8. So now let's move on to the pathogenesis of EATL. So celiac disease, which is known as gluten sensitive enteropathy, from gluten which is obtained, which is found in wheat, due to the action of small intestine digestive enzymes, there occurs the formation of gliadin amino acid. Now when these gliadin amino acids get attached to the enterocytes, these enterocytes will lead to formation of IL-15. This IL-15 will cause the localization of these T cells within the intraepithelial lymphocytes and also causes the expression of these NKG2D, which is NK activating receptor on these intraepithelial lymphocytes, and the expression of MIC-A, that is non-classic MHC class 1 ligand. Also, and this will cause the destruction of the enterocytes by these intraepithelial lymphocytes, that is cytotoxic T cells. After the destruction of these enterocytes, the gliadin will move to the lamina propria, and with the help of tissue transglutaminase, these gliadin will form deaminated gliadin. Now this deaminated gliadin will be presented by antigen presenting cells, and these, with the help of HLA, DQ2 and DQ8, the T helper cells will recognize these deaminated gliadin and HLA, and they will lead to secretion of certain cytokines like interferon gamma, and they will activate the B cells to produce anti-gliadin, anti-endomysial and anti-TTG antibodies. Now, these interferon gamma and other cytokines will cause further destruction of the enterocytes by the intraepithelial T lymphocytes. So, when this response is persistent or long-acting, it causes DNA damage, genomic alterations, inhibition of intraepithelial lymphocyte apoptosis, clonal expansion of these intraepithelial lymphocytes, and progression to enteropathy-associated T-cell lymphoma. So these EATLs are positive for CD3, CD7 and CD103. They are also positive for cytotoxic marker, that is TIA1, granzyme B and perforin. The de novo EATL may be positive for CD8, and the larger cells are usually positive for CD30, and at times they are positive for EMA. However, they are negative for CD4, CD8, CD5 and CD6. So the EATLs have got a very poor prognosis, and they have given a separate prognostic index, EPI, based on presence of B symptoms and International Prognosis Index scores. We'll discuss about IPI score later on. So after EATL, let's move on to case number 4. So now we have a 63-year-old gentleman who presented with pain, abdomen, diarrhea, and weight loss. His test for occult stool blood test was positive. There was no history of any malabsorption or celiac disease. On endoscopy, ulcerative mass in the jejunum was found, and on abdominal CT, mesenteric lymph node was enlarged with a maximum dimension of 3.5 centimeters. Resection was done, and we found that there is, so this is the intact mucosa, and we can see that there is transmural infiltration of the small bubble wall with ulceration. However, there is no necrosis. Also, the adjacent mucosa show expanded and distorted intestinal villi, and they contain epitheliotrophic lymphoma cells. Now, these epitheliotrophic lymphoma cells are present predominantly in the periphery of these glands, and they are cytologically atypical. They are medium-sized lymphoid cells which has got irregular nuclear contour, moderate nuclear pleomorphism, more open chromatin, distinct nucleoli, and ample amount of clear cytoplasm, with few intermixed inflammatory cells. They also show pleomorphic morphology, so some with presence of occasional larger cells, and they can also show high-grade appearance with frequent apoptotic bodies and macrophages, which imparts them a starry sky appearance. On immunohistochemistry, they show positivity for CD3, CD8, CD56, and they show nuclear positivity for megakaryocyte-associated tyrosine kinase. Now, the distant mucosa show preservation of villus architecture, but there is increased intraepithelial lymphocytes. So, it is important to see that they are not showing features of celiac disease. On higher power view, we can see that these intraepithelial lymphocytes are showing bland appearance. They have got a round nuclei, condensed chromatin, and inconspicuous nucleoli. So, diagnosis is monomorphic epitheliotropic intestinal T-cell lymphoma. So, what are the essential diagnostic criteria? If the intestine is densely infiltrated by monotonous medium-sized T lymphoid cells, They typically lack necrosis. The epithelial invasion is commonly present, that's why they are called epitheliotropic. And the most common immunophenotype is positivity for CD3, CD8, CD56, and cytotoxic markers like granzyme, perforin, or TIA1. So these are derived from intraepithelial T lymphocytes. They are characterized by monomorphic cytomorphology and epitheliotropism. They typically lack celiac disease association. On immunophenotyping, they show positivity for CD2, CD3, CD7, CD8, and CD56. They're positive for cytotoxic markers. Nuclear positivity for megakaryocyte-associated tyrosine kinase. CD20 can be aberrantly seen in around 20% of the cases. They've got a very poor clinical outcome and the median survival of 7 months. So this is my hometown Jaunpur. It was a center of great learning during the medieval India, and that is why it was known as Shiraz of East. So after 4 cases, let's move on to the case number 5. So now we have a 69-year-old gentleman who presented with abdominal pain, diarrhea, and weight loss. His occult stool blood test was positive. On CT abdomen, mesenteric lymphadenopathy of 4 cm was noted. On endoscopy, there was mass with ulceration with a dimension of 3.5 by 3 centimeters. A resection was done and it showed a large tumorous lesion. There is transmural infiltration of these blue looking cells, and on higher power view we can see that these cells are large, and also we can see that there is presence of surface ulceration. So this is the intact lining and this is the surface ulceration. So on a closer look we can see that there is a monotonous population of these large atypical lymphoid cells. These cells show strong membranous positivity for CD20. They show positivity for BCL2. More than 40% of these cells were positive for MUM1, and they were also positive for PDL1. So MUM1 is post-germinal center marker. So the diagnosis is diffuse large B-cell lymphoma, ABC phenotype. And now let's see what are the essential diagnostic criteria of DLBCL. So there has to be diffuse infiltrate of atypical large lymphoid cells. They will be immunoreactive for B lineage markers like CD19, 20. They will lack immunoreactivity for EBV virus. So they can involve any part of the GIT, we all already seen. However, they most commonly involve stomach and ileocecal region. They can also involve the liver, in which case the patient will present as pain, abdomen, and mass. These are the most common GI lymphomas and seen in 55 to 69% of the cases. And patients with immunodeficient profile are more prone. They are of germinal center B cell type or activated B cell type. Now coming to the genetic subgroup, they can be double hit when mixed with either BCL2 or BCL6 rearrangements are present. They can be triple hit also when there will be mixed with BCL2 and BCL6 rearrangement. So BCL2 rearrangement is almost exclusively seen in GCB type DLBCL, and BCL6 rearrangement is seen in around 25% of the DLBCL, and it is more commonly associated with activated B cell type phenotype. So this is the other subtypes. So this is CD10 and BCL6. So we know that these two are germinal center markers. So these neoplastic cells can be positive for these two immunophenotype. And in case of double hit lymphomas phenotype, they will be positive for MYC and BCL2. So on immunophenotyping, they will be positive for one or more BCL marker, that is CD19, CD20, CD79A, PAX5 or surface or cytoplasmic immunoglobulins. They'll be positive. The GCB, germinal center B cell type, will be positive for CD10, BCL6, GCT1, LMO2. The activated B cell type will be positive for IRF, MUM1 and FOXP1. Now coming to the prognosis. So extranodal DLBCL have a tendency to localize in their anatomical sites. So they are prognostically more favorable than the nodal equivalents. However, the ABC DLBCL have got a worse prognosis, and with the presence of TP53 cyclin dependent kinase 2A deletion, particularly in combination with trisomy C, has got a poorer survival. So after the DLBCL, let's move on to the case number 6. Now we have a 50-year-old lady. She was farmer by occupation. We are seeing farmer protests these days. And she presented with abdominal discomfort and black tarry stool. On endoscopy, there was presence of varying size polyp, and it was seen in jejunum. Resection was performed, and it showed the presence of there was a transmural replacement by closely packed abnormal lymphoid follicles. These are the neoplastic lymphoid follicles. So now you can recognize the neoplastic lymphoid follicles. There is absence of mantle zone, there is absence of polarity, there is absence of tangible body macrophages. So these cells, so here the cells in both follicular and interfollicular areas are positive for CH20, and these follicles are showing strong positivity for BCL2, which is also a character of neoplasm. So the diagnosis is follicular lymphoma. So what are the essential diagnostic criteria? So here the lymphoid proliferation will be there with cytological features of follicular center cells, that is centrocytes and centroblast. At least focal atypical follicle formation will be there, there will be crowding, loss of polarization, lack of tangible body macrophages. These B-lineage neoplasm will express follicular center cell markers, that is CD10 and BCL6, and they will be positive for BCL2. Now follicular, these are a rare lymphomas of the GIT, and most of them are of grade 1 and 2. So how to grade follicular lymphoma? So these are basically graded based on the absolute number of centroblasts per high power field, that is on 40x objective. So grade 1 is given when there is 0 to 5 centroblast, grade 2 when there are 6 to 15 centroblast, grade 3 when there are more than 15 centroblast. In grade 3 itself there is A and B. Grade 3A will have centrocytes, but grade 3B will have solid sheets of centroblast. So these follicular lymphoma will have their hallmark translocation, that is translocation 1418, that is between IGH BCL B receptor, B cell receptor, and BCL2, that is anti-apoptotic gene, in around 90% of the cases. And on histology, there will be multiple polyps in small and large intestine, which are also known as lymphomatous polyposis. So we have also seen duodenal type follicular lymphoma and this follicular lymphoma, which is present in the GIT. So definitely these are different. Now how these are different? So duodenal type, as the name itself suggests, they are present in the duodenum. Whereas follicular lymphoma, they can be seen in both small and large intestine. Duodenal type follicular lymphoma involve only the mucosa and submucosa, whereas follicular lymphoma is usually show transmural infiltration. The pattern of follicular dendritic cell meshwork, which was redistributed to the periphery in case of duodenal type follicular lymphoma, is very well preserved in case of this follicular lymphoma. The duodenal type follicular lymphoma has a better prognosis in comparison to the follicular lymphoma of the GIT. On immunophenotyping, they will be having similar marker as the nodal follicular lymphoma, that is they will be positive for B cell marker, that is CD19, CD20 and or PAX5. They will be positive for germinal center marker, that is CD10, BCL6. However, this will be down-regulated in case of the lymphomas situated in stomach and colorectum. They will be positive for BCL2, and they will have well-preserved follicular dendritic meshwork, which is appreciated by CD21. So there is International Prognosis Index for non-Hodgkin's lymphoma, and there is separate IPI index for follicular lymphoma itself. So FLIP1 has 5 adverse prognostic risk factors, which includes age and arbor staging, hemoglobin level, number of lymph node areas involved, and serum LDH level. A patient with an age of more than 60 years will have a poor prognosis, and arbor stage 3 and 4 will have a poor prognosis. Patient with hemoglobin of less than 12 gram per DL will have a poorer prognosis. The number of lymph nodes more than 4 involved will have a poor prognosis, and highly serum LDH will have a poor prognosis. So based on these, a scoring is given, and they are stratified into low risk, intermediate risk, and poor risk. So this risk stratification shows what is the prognosis of these individuals. So after follicular lymphoma, let's move on to case number 7. So now we have a 60-year-old gentleman who presented with abdominal discomfort and generalized lymphadenopathy. On endoscopy, there was multiple intestinal polyps, which was 0.5 to largest 3 centimeters in maximum dimension. Biopsy was done, and it showed predominant involvement of the lamina propria and the submucosa, and there were some follicles which were showing homogeneous population of involvement of the submucosa. So these are blue looking areas, so they are lymphoma infiltration, and on higher power view you can see that these cells are centrocyte look like, that is, they have got round oval shape with nuclear indentation, and they were positive for cyclin D1. So yes, we are dealing with mantle cell lymphoma. So what are the essential diagnostic criteria? So there will be diffuse nodular to mantle cell proliferation of small to medium sized cells with irregular nuclear contours, dispersed chromatin, and inconspicuous nuclear. They can be blastoid or pleomorphic subtypes, which will show different cytological features. So these B cell neoplasm will express CD5 and cyclin D1. If you remember that these mantle cell lymphoma are pre-germinal center lymphoma, which arises from the naive B cells. So they are often positive for SOX11. So the desirable diagnostic criteria is when they have got a morphological feature suggestive of mantle cell lymphoma, that is irregular nuclear contour, dispersed chromatin. However, they are positive for CD5, but they are negative for cyclin D1. In such cases, diagnosis has to be confirmed by SOX11 immunohistochemistry or by looking at the translocation of cyclin D2 or cyclin D3. So apart from the routine morphology, we can also see blastoid or pleomorphic morphology. In case of blastoid morphology, these cells will look like lymphoblasts, so they will have a round to oval shaped nuclei with vesicular chromatin, opened up chromatin, and 1 to 3 prominent nucleoli. And in case of pleomorphic variant, they will have highly pleomorphic cells. Some can be multinucleated, multilobated as well, and some can be very bizarre or large looking. So these mantle cell lymphoma are mature B cell neoplasm. They usually comprise of monomorphic small to medium sized lymphoid cells with irregular nuclear contours that commonly express CD5. In more than 95% of the tumors, they carry translocation 1114, that is cyclin D1 and IgH gene translocation, which lead to cyclin D1 overexpression. So they are divided into conventional type mantle cell lymphoma and leukemic non-nodal mantle cell lymphoma. When they come into the peripheral bed and they present as leukemia. So subclinical tumor cell infiltration is in the GIT is a common presentation. Lymph nodes are also commonly involved with frequent involvement of the extranodal sites. So most of the patients present in stage 3 and 4 with lymphadenopathy and bone marrow involvement. Now there is in situ mantle cell lymphoma also. So whenever the cyclin D1 positivity is restricted to the inner mantle zone, then they are called in situ mantle cell lymphoma. On IHC, they will be positive for mature B cell marker, that is CD20, CD79A, CD5, CD43. Cyclin D1 will be seen in more than 95% of the cases, and SOX11 comes in handy when there is cyclin D1 negativity. LEF1 is positive in blastoid and pleomorphic subtypes, and CD200 will be seen positive in 40 to 90% of the cases of leukemic non-nodal mantle cell lymphoma. For prognosis, Ki67 proliferation index is most important independent factor. So this is the pathogenesis, molecular pathogenesis of mantle cell lymphoma. So a pre-B cell, which can be either cyclin D1 positive or negative, will give rise to naive B cell, and then these naive B cell will move to mantle cell, inner mantle cell, and then they will be in situ mantle cell neoplasia. Now, when they will acquire SOX11 positivity and they are present within the mantle zone itself, they can either go into the extranodal sites and they can form classical mantle cell lymphoma, or they can acquire certain mutations like TP53 and other oncogene abnormality to become blastoid or pleomorphic mantle cell lymphoma. Or these in situ mantle cell lymphoma cells will transfer to the germinal center where they will be they will and when they transfer to the germinal center, the SOX11 becomes negative, and then they can become a leukemic non-nodal mantle cell lymphoma when they go into peripheral blood, bone marrow, or spleen, and they can further progress to pleomorphic mantle cell lymphoma after acquiring TP53 or other oncogenic abnormality. So mantle cell has also got an international prognostic index, just like follicular lymphoma. So points are given from 0 to 3, and there are 4 factors which are considered: age, ECOG performance status, LDH level, and WBC count. So in MIPI, proliferation marker Ki67 has a very high prognostic relevance independent of this MIPI score. For each these prognostic factors, 0 to 3 points are given, as we have already seen, and points will be sum up to a maximum of 11. So the patient will be stratified on low, intermediate, and high risk based on these points. If they are 0 to 3, they are low risk. 4 to 5 points will have intermediate risk, and the patients on 6 to 11 points will on high risk. And the ECOG performance status is weighted on 2 points, that is 0 to 1 and 2 to 4. So this is Banaras, one of the oldest city and spiritual capital of India. Let's move on to the last most common case, case number 8. Now we have Master A, who is a 14-year-old. He presented with the lower abdominal pain, vomiting, constipation, weight loss. On complete blood evaluation, he was found to have hemoglobin anemia with a hemoglobin of 6.4 gram per dl. CT abdomen show mass lesion in the appendix, so resection was done, and this is the cut surface of the appendix, which is showing grey-white fleshy cut surface. With this size of this lesion is 1.5 to 2 centimeters in the longest dimension. And on microscopy, you can see that there is diffuse proliferation of regular cohesive cells with starry sky pattern in between. And on further higher power view, we can appreciate that these cells are monotonous. They are medium-sized lymphoid cells with squared off borders. You can see that these are squared off borders with finely clumped nuclei chromatin, and there are multiple basophilic nucleoli. So on Ki67, they show almost 100% positivity. They were positive for germinal center marker CD10. They were negative for BCL2, and they were positive for MYC translocation. So yes, this is Burkitt lymphoma. So the classical features, there is diffuse monotonous infiltrate of medium-sized lymphoid cells with squared off contours, round nuclei with finely clumped chromatin, multiple nuclei, and basophilic cytoplasm. They will have numerous mitotic figures and apoptotic bodies, and on immunophenotyping, they will show B cell lineage marker positivity, that is CD19, 20, 22, CD79, PAX5. They will be positive for germinal center marker, that is CD10, BCL6, and will be negative for BCL2. MYC protein expression is seen in 80% of the neoplastic cells, and they will show near 100% Ki67 positivity as a proliferation index. So there can be cases with deviation also. Like in such case, the morphology and immunophenotype will be atypical. There will be expression of MYC protein will be less than 80%. So 80% is the cutoff to say whether MYC protein is positive or negative. If it is more than 80%, then MYC protein expression is taken as positive. If it is less, then it is taken as negative. There has to be additional testing is required to confirm the diagnosis of Burkitt lymphoma in such cases, and for it, FISH analysis for MYC, BCL2 and BCL6 rearrangements are required. Additionally, 11q abnormality is also done, tested to exclude these three entities. What are these three entities? High-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement, high-grade B-cell lymphoma NOS, or Burkitt-like lymphoma with 11q abnormality. So the classical Burkitt lymphoma is a highly aggressive B-cell lymphoma. It is characterized by frequent presentation in the extranodal sites or as an acute leukemia. It has got a high proliferative activity. MYC gene translocation occurs to the immunoglobulin locus, and in the GIT, the most frequent site of involvement is ileocecal region, followed by stomach, small intestine, and ascending colon. They often present with a bulky disease and very high tumor burden due to short doubling time of the tumor. So Burkitt lymphoma is subdivided into three types: endemic, sporadic, and immunodeficiency associated. Endemic ones are predominantly seen in Equatorial Africa, Papua and New Guinea, which are endemic for malaria. They are seen in age group of 4 to 7 years, and it is the most common childhood malignancy in this region, with a predominance in male patients. The EBV genome is present in more than 95% of these cases, and they are usually polymicrobial by etiology. They are associated with EBV as well as Plasmodium falciparum. The sporadic ones are seen throughout the bird. It is seen in both children and younger adults. It is also most prevalent in male age groups with the EBV genome positivity in 20 to 30% of the cases. Immunodeficiency associated Burkitt lymphoma is usually seen in regions with HIV infections, and they are also associated with EBV as well as HIV. So let's see about a MYC gene. So MYC is a proto-oncogene. It's important in case of Burkitt lymphoma and other. It activates the expression of many genes that are involved in cell growth. It upregulates the expression of telomerase and transcription factors that can act together to reprogram somatic cells into pluripotent stem cells. So IGH is an antigen receptor gene locus which contain enhancers that are highly active in lymphocytes. So in case of Burkitt lymphoma, the molecular hallmark is translocation 814. There is translocation between MYC and IGH genes. So rather than driving expression of B and T cell receptors by a IGH gene, these misplaced enhancers cause deregulation and overexpression of MYC protein, and that's why this proto-oncogenes become oncogene, and the cell becomes neoplastic. Burkitt lymphoma is a highly aggressive but potentially curable tumor. It responds to intensive chemotherapy, and it can result in long-term overall survival of 70 to 90%. Children perform better than adults. Adverse prognostic factors are advanced stage disease, bone marrow and CNS involvement, unresected tumors that is 10 cm or more in diameter, and high serum LDH levels. So that's the end of the common GI lymphomas. Let's move on to the rarer GI lymphomas. So I'll be discussing very briefly about these rarer ones. So first is hepatosplenic T-cell lymphoma. These are aggressive extranodal lymphoma which are characterized by proliferation of cytotoxic T cells. These are usually gamma delta T cells. If you can recall, these gamma delta T cells are usually seen in the mucosa, spleen and skin with a hepatosplenic presentation and no lymphadenopathy. The essential diagnostic criteria is they are uniform medium-sized lymphoid cells with indistinct nucleoli. They have got a sinusoidal localization in liver, spleen and bone marrow. They'll show cytotoxic T cell phenotyping with TIA1 expression. The desirable diagnostic criteria, the usual expression is of T cell receptor gamma delta, but sometimes they can show alpha beta receptor expression also. They're usually EBV negative. So this is a panel of photograph. In the first, which is taken from the spleen, it shows cords and sinusoids of spleen which are infiltrated by these monotonous population of neoplastic lymphoid cells with medium-sized nuclei and a moderate amount of pale cytoplasm. This section is taken from the liver. which is showing neoplastic cells diffusely infiltrating the hepatic sinusoids with a similar morphology. This section is from the bone marrow. Here also we can see that these sinusoidal infiltration of the neoplastic cells. The IHC on the bone marrow section for CD3 is better highlighting these lymphoma cells. Indolent T-cell lymphoproliferative disorder of GIT. It is as a name, the indolent clonal T-cell lymphoproliferative disorder. It comprises of non-epitheliotropic mature small lymphoid cells that infiltrate the lamina propria. It most commonly seen in involves the small intestine and colon. The essential diagnostic criteria: there has to be non-destructive, non-epitheliotropic small lymphoid cell infiltrate, which should be confined to the gastrointestinal mucosa and or submucosa. On immunophenotyping, they will show T lineage with T-cell receptor alpha beta expression. They will have a low proliferative Ki67, that is less than 10%. So this is endoscopic picture of indolent T-cell lymphoproliferative disorder of the GIT. So this endoscopy is showing from the colon, which is showing small polypoidal lesion, which is hyperemic. This is the duodenal biopsy, which is showing infiltrate and it fills the lamina propria and focally extending beyond the muscularis mucosa. However, glands are largely intact and there is no destruction of the glands. In the ileum, the lamina propria is diffusely infiltrated by these small lymphoid cells. We have seen that proliferation rate, that is Ki67 index, is very low. These lymphocytes are positive for CD3 as well as CD8 with intact glands. So other rare entities are plasmablastic lymphoma, post-transplant lymphoproliferative disorders, which are mostly EBV related, extranodal NK T-cell lymphoma, systemic mastocytosis, LCH, and follicular dendritic cell sarcoma. These are very rare entities, and because of shortage of time, I am not covering these. Now coming to the last section, and the most important, the CAP reporting protocol. So for all non-Hodgkin's lymphoma or any lymphoid neoplasm, these 10 points should be there in your report. So point number 1 is specimen. What is the type of specimen, whether it's lymph node or extranodal site, whether it is GI, stomach, esophagus, any resection specimen, any biopsy. What is the procedure? Whether it's biopsy or excision, whether tumor site, what is the histological type of the lymphoma, what is the pathological extent of the tumor, whether it is involving the bone marrow or any other organ or contiguous lymph node or contiguous organs. What are the additional pathological findings, whether there is any additional like non-neoplastic pathological findings like celiac disease, or whether there is a H. pylori infection, whether we have done immunophenotyping or not by flow cytometry or by IHC. If the cytogenetic studies are done, then that has to be recorded. If there are molecular genetic studies are done, that has to be reported in the report. And finally, clinical prognostic factors and indices has to be given if they are provided to us by the clinicians. So, what are the factors which determine the treatment in adults in case of GI lymphomas? Specific histological type, stage of the disease, international prognostic index score, and 5 key treatment characteristics which independently statistically significant. Age, less than or equal to 60 years, has got a better prognosis. Tumor stage 1 and 2, which are localized, versus 3 and 4, which are advanced. Number of extranodal site involvement, 0 or 1 versus more than 1. Patient's performance status, that is 0 or 1 versus 2 to 4. And serum LDH, the abnormal ones have got a poor prognosis. And so this was the Ann Arbor staging, which was given previously for Hodgkin's lymphoma. So it has got 4 stages, but it is important to see these alphabets. So A at that time means no symptoms, B means presence of 3 symptoms, that is fever with temperature more than 38 degrees Celsius, drenching night sweats, unexplained loss of more than 10% of the body weight within the preceding 6 months. E, which stand for extranodal site, that is contiguous or proximal to the known nodal site, and S stand for splenic involvement. It is important to remember these alphabets. I'll tell why. So So that was the old age, but now we are following AGCC or UICC staging for non-Hodgkin's lymphoma. Here also, there are 4 stages, and stage 1 is given for extranodal or GI lymphomas when there is single extra lymphatic organ or site is involved with the absence of any lymph node involvement. It is given 1E. Stage 2 is given when there is localized involvement of single and extra lymphatic organ with regional lymph node involvement with or without involvement of other lymph node units on the same side of the diaphragm. It is important to note that in case of GI lymphomas, multifocal involvement of a single extra lymphatic organ is classified as stage 1 but not stage 2. And for all stages, tumor bulk greater than 10 to 15 centimeter has got an unfavorable prognostic factor. Similarly, after stage 1 and 2 which are localized, stage 3 and 4 are advanced stages. In stage 3, extra lymphatic extension is associated with associated adjacent lymph node, or there has to be involvement of the spleen or both. And in stage 4, there will be diffuse or disseminated involvement of one or more extra lymphatic organs. There can be isolated extra lymphatic organs, but in conjunction with disease in distant site. That is, there has to be involvement of liver, bone marrow, or nodular involvement of lung or CSF fluid. So this is the ECOG performance status, which is grade from 0 to 4. Actually 5 is there. So 0 means fully active, and 3 and 4 are debilitating conditions. 0 to 2 are like ambulatory conditions. So patients can be assigned from risk group 1 to 4, which is when there is presence of 0 or 1, low intermediate, and high. So low risk patients have got a complete remission of 87% with the overall rate of 73% at 5 years. And high risk patient will have a complete remission of 44% and a 5-year overall survival rate of 26%. Now coming to the A and B symptoms. So A means absent and B means present. This B symptom is not associated with any, whether it is of B cell lymphoma or T cell lymphoma. Please note that. So here, the presence of B symptom is known to correlate with the extent of disease, that is stage and tumor bulk. But the symptoms have to be shown to have a prognostic significance. And what are these? That's fever, unexplained weight loss, and drenching night sweats. So that's it. Thank you for patient listening.
Thank you, Dr. Ojas. Very well done. Excellently explained in a very detailed manner. The good part was the cases which you discussed, all 8 of them were very interesting, and also a very nice way of teaching various aspects of performance, and the inserts were very good, very interesting. There are some questions on the YouTube, which I think I will forward it to you on your WhatsApp chat. You can answer them on the Telegram.
Sure, sir. I'll do that.
Thank you so much. God bless you. Bye-bye. Take care.
Thank you so much. Thank you so much, sir.